गुड इवनिंग मनीष जी, अनम्यूट करिए, अनम्यूट कर बाहर।
क्या सिंह साहब, क्या हाल चाल है?
ये फुल व्यू कर दीजिए।
हाँ सर,
फुल व्यू नहीं है सर।
हो गया सर।
हाँ, दिस फाइन।
Good evening, sir. DP Singh, sir. Good evening.
गुड इवनिंग, गुड इवनिंग।
Manish, good evening.
हाँ, गुड इवनिंग सर।
चलिए, बहुत अच्छा है आप जुट गए।
यस सर।
देख लेते हैं, बहुत वॉइस ज्वाइन करेंगे, नहीं तो जो है हम संजय जी से ही शुरू करवाना है। रुकिए।
नहीं।
सर, प्रणाम सर। एक लाइन चेहरा दिखाई ना बड़ी अभी बस। संजय जी, बुधवार बुधवार वेडनेसडे क्लास है सर।
सर जुट रहे हैं।
हाँ, जुड़ रहे हैं। अच्छा, वेलकम डॉक्टर निर्मल राव।
हेलो, गुड आफ्टरनून, सॉरी गुड इवनिंग आप लोग में। ठीक,
कानपुर, और आर यू इन यूएसए?
नहीं अभी तो इंग्लैंड में ही अभी।
इंग्लैंड में? अच्छा, इंग्लैंड में। अच्छा, चलिए। देखिए, वी हैव गॉट इंटरनेशनल डेलीगेट्स और इंटरनेशनल फैकल्टी हियर इन वेडनेसडे रेस्पिरेटरी मेडिसिन क्लास।
हाँ, तिवारी सर जुट गए हैं सर।
हाँ, प्रणाम सर।
तिवारी सर, प्रणाम सर।
सर, अनम्यूट करिए।
हाँ,
प्रणाम सर।
खुश रहिए देखिए, भाग्य खुश रहिए।
शुरू किया जाए सर।
हाँ, बस।
हाँ,
सर, सर तिवारी सर, 2 लाइन
yes.
आपका ओपनिंग रिमार्क्स।
Well, we have started this course for the benefits of students. We know that government is opening lots of medical colleges in India, but there is shortage of faculty. So, view of API is to educate our students in another way. So, we are doing this extra class for the benefit of students, and teachers like Dr. DP Singh are devoted that they should learn and learn. Dr. DP Singh doing very good job. Let us start the journey. Thank you very much.
Thank you, Dr. Professor Kamlesh Tiwari sir, our Dean, Indian College of Physicians, and welcome Dr. Sanjay Kumar, Joint Secretary at Dean's Place and the famous pulmonologist of Bihar, and other faculties, even Dr. Nirmal Kumar sir joined from UK, and all other delegates who have joined. And today the topic is tuberculosis, diagnosis, management, treatment, and prevention. And we have, it's our pleasure to welcome Dr. Manish Shankar, Professor and HOD Department of Pulmonary Medicine, IGI MS Patna. He has been the Vice President of STF TB Elimination Program. He has been also the expert and convener of difficult to treat TB clinic. Dr. Shankar is a renowned expert in the field of pulmonology and tuberculosis with extensive experience in tuberculosis, pulmonary tuberculosis as well as extrapulmonary tuberculosis. He has been actively involved in the various activities and at the TB elimination program. He is also the nodal officer in BRTB Center. Today, Dr. Shankar will share his expertise on the latest update of TB diagnosis, treatment, prevention, maybe certain special situation like TB and HIV and other situations. So over to Dr. Manish Shankar. Welcome to you in this respiratory class short certificate course under Indian College of Physicians. Over to Dr. Manish Shankar.
Thank you, Dr. Professor DP Singh, sir, Course Director. Thank you, API. Thank you, Dr. Professor Kamlesh Tiwari, sir, Dean, ICP. So I am happy that today the topic assigned to me is tuberculosis, about its diagnosis, management, and the treatment. So we all know TB is very much prevalent in this part of the world, especially Southeast Asian region, and its prevalence is very high, up to the tune of 27% in India. But if we talk of Global TB Report 2022, you can see the comparison between WHO estimates and India estimates. If you will see the incidence per lakh population, it is progressively declining from 2012 to 2022. You can see that it is declining from almost from 250 to around 210 around. Similarly, mortality per lakh population is also declining significantly in the last 10 years or so. Similarly, trend in TB incidence, you can see total incidence in India is also declining, and in new and relapsed TB notified cases and HIV positive incidence is also progressively declining. Similarly is the mortality. So what is the natural history of tuberculosis? So we all know that tuberculosis spreads from the diseased person to the susceptible person by coughing and sneezing, and its bacilli spreads via droplets to the susceptible individuals. It lodges into the lung with following possible consequences. Either it is immediately cleared, or there is TB infection, that is called latent TB, but there is no TB disease. Then primary tuberculosis and reactivation or post-primary tuberculosis. So what happens? It is only 5% of the individuals, despite established infection, they do not remain infected, so they remain uninfected. Rest of the individuals, there can be TB infection, which is called latent TB, where TB infection is there, TB bacilli lodges in the lung, and due to effective cell-mediated immune response, there is granuloma formation, and live TB bacilli is contained within that granuloma that does not spread further. That is called latent TB infection. So there is TB infection, but there is no TB disease. And this is diagnosed by either we do tuberculin skin test or IGRA test, that is interferon gamma release assay. Second outcome is there may be a primary TB disease. Means TB infection once occurs, causing destruction of the lung parenchyma, is disseminated to the other organs. It usually occurs in the children or immunocompromised individuals. But it can occur in the absence of, or means that it can occur in a healthy individual, only 5% of the individual with intact immunity. So this is called primary TB disease. And the reactivation pulmonary tuberculosis is, there is history of latent TB. There is latent TB, there live bacilli is there, which is residing in the granuloma due to effective cell-mediated immunity. But once immunity declines, either due to immunosuppressive conditions or patients is having HIV infection or in the extremes of ages, so it reactivates and then spreads to then it infects the lung parenchyma or the other organ. So there is a reactivation of tuberculosis. So this is called post-primary tuberculosis. So what is the lifetime risk of developing post-primary tuberculosis or reactivation? It is around 10%. But if the patient is having HIV or so, there is lifetime 60% lifetime risk of developing post-primary or reactivation tuberculosis. So some points about microbiology, pathogenesis, and immunology. So we have got three types of immunity against tuberculosis infection. One is innate immunity, other is granuloma formation, and the third is adaptive immunity. So these immunity are very effective in controlling tuberculosis infection. So that most of the individuals after TB infection do not develop clinical disease. These types of immunity are involved in trying to control and eliminate Mycobacterium tuberculosis. How innate immunity works? It works with host defense against Mycobacterium tuberculosis by the use of receptors for Mycobacterium tuberculosis molecules, and these kill via reactive nitrogen intermediates. Granuloma formation occurs due to cell-mediated immunity, and it is a host protective factor, and it provides a shelter for long-term survival of the tuberculum bacterium within the host. So there is a granuloma formation, TB bacilli resides within the granuloma. It may remain there lifelong. So this type of infection is called latent infection. And these granuloma are very effective in controlling the spread of infection. And the third is the adaptive immunity. It is very critical component of the immunity against Mycobacterium tuberculosis. What happens when once Mycobacterium tuberculosis bacilli invades the lung parenchyma, infects the lung parenchyma, arrives there, there is macrophages and phagocytic cells which phagocytose those organisms, and they transmit it to the draining lymph node. And there at the draining lymph node, that mycobacterial tuberculosis antigen is presented to the T cells, and that induces an adaptive immunity. And it takes about 6 weeks after the infection. So tuberculous bacilli, when lodges into the lung, and there is macrophages which form tubercle, that is tuberculoma, around the tubercle bacilli. And when we take X-ray of those patients, then those tubercles is called Bohn's focus. So Bohn's focus is the radiological nomenclature of infection tubercle formed by the tubercle bacilli. These tubercles then transmits to the draining lymph node. These bacilli then transmits to the draining regional lymph node via the lymphatic channels. So it causes, so when it is drained to the regional lymph node, then it causes Bohn's focus along with lymphangitis and draining lymphadenopathy. Whole complex is called Bohn's complex. And these Bohn's complex, when undergoes calcification, it is called Ranke complex. So Bohn's lesion and Bohn's complex is observed in TB infection and primary TB disease. So primary TB disease, as I have already told, that it is the immediate onset of TB disease following Mycobacterium tuberculosis exposure in a previously NAV host. So these type of hosts fail to mount an effective immune response. These lead to progressive tissue destruction and spread of the bacilli. The bacilli migrates from the lung via lymph nodes, via lymphatics and bloodstream to the other organs, and it can produce disseminated tuberculosis. What are the signs and symptoms of primary TB disease? Fever is the first and foremost. Pleuritic or retrosternal pain can occur in 25% of cases. Pleural effusion occurs predominantly in the primary TB disease, and rare symptoms can include fatigue, cough, arthralgia, and it can also cause pharyngitis and so on. What will be the radiology of the primary TB disease? It will be bones complex. It can be regional lymphadenopathies. If it is in lung, then hilar or mediastinal lymphadenopathy. Pleural effusion occurs in 33% of cases, and pulmonary consolidation can occur in 27% of cases. So you can see the radiology. You can see the hilar and mediastinal lymphadenopathy in primary tuberculosis cases. This is the radiograph showing prominent hilum, and there is widening of the right paratracheal stripe. You can see in the yellow arrow. You can see in the CT thorax, you can see the right hilum, hilar lymphadenopathy, it predominant, and right paratracheal lymph nodes, you can see it is enlarged. In the other figure, you can see in the radiology, there is right middle lobe consolidation. And similarly, in CT thorax also, you can see the right hilar lymphadenopathy. And you can see here is lymph node is also there with some central hypoattenuated shadow. This hypoattenuation reflects necrosis of the lymph node, which is highly prevalent in tuberculosis infection. Now, few points about post-primary TB disease. Predominant signs and symptoms are cough, loss of weight, fatigue, fever, and with night sweats occur in almost 50% of cases. There can be chest pain, dyspnea occurs in 1/3 of cases, and there can be hemoptysis. If we see the radiology, there can be consolidation, there can be cavity predominantly in the upper lobe, there can be effusion, there can be fibrobronchiectasis, and there can be sequelae of the post-primary infection, can be calcifications and traction bronchiectasis. You can see tree in bud appearance in post-primary tuberculosis also. What is tree in bud appearance? There is predominantly 2 to 4 millimeter centrilobular nodules with branching linear opacity, which is called tree in bud, and it represents intrabronchial and peribronchial scagiation necrosis. If we see the post-primary tuberculosis radiology, you can see here that there is right upper zone infiltration. You can see in the chest radiology, and in CT, you can see there is right upper lobe cavity with surrounding consolidation. There is consolidation with scattered nodularity. You can see here is there is cavitation. So once you see this type of picture, you can diagnose immediately that this is post-primary tuberculosis. So once a patient is infected with tuberculosis, what is the transmission risk to the others? So once there is pulmonary and laryngeal tuberculosis, there is high risk of transmission to the others, because pulmonary and laryngeal tuberculosis patients usually coughs and sneezes, and bacilli spread to others via the droplet infection. There can be presence of cavitary disease. If there is cavity in the lung, then there is a high chance that the tubercle bacilli, that person can transmit tubercle bacilli to the other susceptible or vulnerable population. If sputum smear examination is positive, then also there is high risk of tuberculosis transmission. And frequent coughing, singing, or sneezing, and or patient is on ATT, but anti-tuberculosis therapy, but this is ineffective TB treatment, then also there is high risk that TB can be transmitted to the others. So once you suspect, so how will you diagnose a case of tuberculosis? So basic thing first, you will do blood test. So what we expect in hematological examination? there can be normocytic anemia, there can be leukocytosis, or rarely monocytosis. CRP is high in almost 85% of cases. There can be hypoalbuminemia and gamma globulinemia. You can also see. So once you suspect a case of tuberculosis, first and foremost, what you will do? You will do sputum smear microscopy examination. So there must be for sputum smear microscopy to be positive, some prerequisite is there. First and foremost, patient should give good quality sputum, minimum about 2 ml of sputum, and sputum should contain at least 10,000 bacilli per ml of sputum. That then only it can be detected under microscopy. And the staining used is called Gill-Nielsen staining. The sensitivity of sputum microscopy is between 45 to 80%, and specificity is also 50 to 80%. If we use fluorescent microscopy, then its sensitivity improves further, and it can detect about 1,000 colony forming units, 1,000 bacilli per ml is there, then it can be detected by fluorescent microscopy. Culture is by far the most sensitive test to diagnose tuberculosis. As minimum as 10 bacilli per ml can also be detected by the culture. But only caveat is culture growth takes around 2 to 6 weeks. So the sensitivity of culture is around 80% and specificity is 98%. We use two types of culture. Solid culture, that is called algae media, and now more widely used is liquid culture, that is Bactec MGIT 960. Liquid culture is more advantageous over solid culture. It is more sensitive, and time taken by liquid culture is far less than solid culture. So this is you can see the bacilli, red bacilli, acid fast bacilli, you can see by the Gill-Nielsen staining in the sputum microscopy. So to establish a diagnosis, we can do either a phenotypic test or can do a genotypic test. Phenotypic test, we do sputum smear microscopy, or we can take sample from bronchoalveolar lavage, or we can take sample from pleural fluid, or we have, if lymph node is there, we can aspirate the pus, or if there is any lump is there, we can take the biopsy, we can make a smear, and we can diagnose. These are the thing by which we can diagnose tuberculosis. These are called phenotypic test. We can do culture also. And the genotypic tests, which are by far the more widely used now, are of two types. One is probe-based and other is sequence-based. Probe-based is non-sequencing test, and then sequence-based. Probe-based, we all know, almost everyone knows, that is CBNAT, that is NAT testing, and other is TrueNAT. No. So CBNAT and TrueNAT are sufficient for diagnosis of tuberculosis. CBNAT is an automated test. It diagnoses not only TB infection, but it also diagnoses rifampicin resistance. Similar is with TrueNAT. CBNAT needs uninterrupted power supply and refrigeration, air conditioned system, but TrueNAT is more advantageous because it can be used, it is chip-based test, and it is battery operated, and it can be used in the peripheral setting also, because this does not need a air conditioned system. So what are the difference between probe-based and sequence-based assay? So basic difference is probe-based test detect whether there is a gene mutation is present or not. That is RPO beta gene. RPO B gene, if it detects, then it is rifampicin resistance it detects. But it can also detect some silent or missense mutation by probe-based assay, which does not represent a resistant pattern. Okay, because not all gene mutation within a given region confirm drug resistance. There are some silent or missense mutation that can also be picked up by the CBNAT or TrueNAT, and those results can say that there is resistance. But when we do culture of those sputum or sample, they come out to be drug sensitive test. So major advantage of sequence-based assay is that it can provide information regarding the nature of the specific mutation and therefore can predict whether drug resistance is there or not with greater accuracy. Okay, so if a probe-based assay is suggestive of resistance, and this should ideally be confirmed with a sequence-based assay or by culture. So there are several sequence-based assay available. We all know that is Sanger sequencing, there is Pyro sequencing, whole genome sequencing, next genome sequencing. These are the sequence-based assay that is more confirmatory than probe-based assay. So probe-based assay, we have CBNAT, that is called expert MTB RIF assay. It can detect not only tuberculosis, but it can also detect rifampicin resistance by looking for the RPO B gene. Other is more refined is expert MTB ultra assay, that is called Gene Expert Ultra. It is found to be more sensitive than Gene Expert for the detection of MTB, even in smear negative but culture positive specimens, and also in extra pulmonary specimens, and also in specimens from individuals with HIV infection. Sensitivity of expert ultra is high than Gene Expert. It is almost around 88% as compared to Gene Expert, which is 83%, but its specificity is somewhat low against the Gene Expert. Sequence-based assay can provide the genetic identity of a particular mutation and can predict drug resistance with greater accuracy than probe-based assay. So what is the laboratory turnaround time for the various TB tests performed under National Tuberculosis Elimination Program? We all know, I have already discussed, that is solid culture, that is Levinson-Jensen's median. It takes around 3 weeks in a smear positive samples, but almost around 8 weeks for smear negative sample. Then there is liquid culture. It takes very much less time against the solid culture. This is called Bactec MGIT culture system. This is automated liquid TB culture. And it takes around 10 days for smear positive samples and around 2 weeks to 6 weeks for smear negative samples. Then there are phenotypic tests, that is Gene Expert CBNAT. I have already discussed. It takes around only 2 hours. And TrueNAT also takes around only 2 hours. Then one is a line probe assay. Line probe assay can detect TB and also can detect drug resistance against rifampicin, isoniazid, fluoroquinolones, and second-line injectables. And it takes around 1 to 3 days to detect. So only thing is we must remember that line, if there is smear positive sample, then line probe assay can be done directly on the sputum sample. But if smear is negative, then we should do culture first, and then isolates from culture should be subjected for line probe assay. Then there are some rapid TB identification tests, that is called immunochromatographic assay, that can also be used for diagnosing tuberculosis, but these rapid TB identification test has not been included in the program yet. So what are the diagnostic parameter of TB? Once a patient with cough, fever, night sweat, loss of weight for more than 2 weeks is there, then this patient should be diagnosed under presumptive pulmonary TB patient. They should be subjected to a designated microscopy center for a quality sputum CBNAT test, and those patients should also be subjected for chest X-ray if CBNAT is negative. So all presumptive TB patients must be subjected to CBNAT in all where CBNAT is available. So upfront CBNAT test should be done in a presumptive pulmonary tuberculosis patient, and chest X-ray and where CBNAT is negative and there is a high suspicion of tuberculosis, then we should do radiology of those patients. So diagnostic algorithm of pulmonary tuberculosis, if there is presumptive TB cases, we should do sputum examination and or chest X-ray. If sputum smear is positive, chest X-ray is suggestive of TB or not suggestive of TB, but smear is positive, then we should do. Then these patients are subjected for CBNAT. If MTB is positive, then we should look for rifampicin resistance or sensitive. If rifampicin sensitive, then we should treat by drug sensitive TB regimen. If resistance, then drug resistant TB regimen. If rifampicin is indeterminate, then we should subject another sample to reconfirm, second sample to reconfirm whether there is rifampicin sensitive or resistance. Suppose if chest smear is negative, but chest X-ray is suggestive of tuberculosis, those patients should also be subject for TB treatment. And if chest X-ray and sputum smear examination or sputum CBNAT both is negative, but the physician thinks, or this is upon physician discretion to decide whether these patients are tuberculosis case and these patients should be given tuberculosis. It all depends upon the physician decision ultimately. What are the different complications? Hemoptysis. Number of patients are coming in the OPD with hemoptysis, and we subject those patients for tuberculosis evaluation. Pneumothorax occurs in around 1%. Bronchiectasis can occur as a sequelae of tuberculosis. Lung abscess, broncholithesis, extensive pulmonary destruction. There can be respiratory failure. There can be pleural effusion. One important thing is TB is also a risk factor of malignancy and lung malignancy, and it has been seen that there is 1.78-fold increase in the risk of lung cancer among non-smokers, and there is a high chance of development of adenocarcinoma, relative risk of 1.6. In a patient with TB, they can develop malignancy. So once we diagnose tuberculosis and once we are confirmed that this is drug-sensitive TB, then as per National Tuberculosis Elimination Program, we should give those patients for treatment regimen for drug-sensitive TB cases. So these patients are treated for 6 months of TB treatment. 6 months, if we said 6 months, that means 8 weeks, that is 56 doses of isoniazid, rifampicin, pyrazinamide, ethambutol, followed by 16 weeks, that is 112 doses of isoniazid, rifampicin, and ethambutol. Okay, so this pyrazinamide is omitted in the continuation phase. The first 2 months, that is 8 weeks, is intensive phase, and 4 months, that is 16 weeks, is continuation phase, that is called CP. So all the doses should be given daily, not intermittently. That is very important point, that all the doses should be given daily if this is a case of pulmonary tuberculosis cases. But if suppose patient is having CNS TB, a skeletal TB, disseminated TB, or patient has not responded yet to the 6 months of the standard doses, that can be extended based on the physician decision and case to case basis up to 24 weeks in certain forms of TB like CNS TB or skeletal TB. So if a patient is adult, then adult TB treatment is isoniazid. We give at a dose of 5 milligram per kilogram body weight, rifampicin 10 milligram, pyrazinamide 25 milligram, ethambutol 15 milligram. Streptomycin previously was included as a first-line drug. Now it has been shifted to the as a reserve drug for the drug-resistant TB cases. But streptomycin should be used in CNS TB cases because injectable aminoglycosides have got better penetration in the inflamed meninges. So pyridoxine should be given at a dose of 10 milligram per day in each and every individuals. And now, under program, TB drugs are given in a fixed dose combination. That is called FDC. And one FDC tablet has got isoniazid 75 milligram, rifampicin 150 milligram, pyrazinamide 400 milligram, and ethambutol 275 milligram. Okay. And there is a weight band. Weight band is 25 to 34 kg, 35 to 49, 50 to 64, 65 to 75, and more than 75 kg. Suppose a patient falls between a weight band 25 to 34, then we will have to give 2 tablets. If it is between 35 to 49, then 3 tablets, and so on up to, if it is more than 75 kg, then 6 tablets of FDC, that is fixed dose combination. Okay. One important point is, suppose a patient during treatment shifts from one weight band to the other weight band. Suppose before the start of treatment, his weight was 33 kg, and now his weight is 36 kg. Then how many numbers of tablets will you give? Answer is, you will still give 2 tablets until unless weight has increased by more than 5 kg and patient has been shifted to or crossed to the next weight band. Then you will give the next weight band dose. Suppose a patient is having extrapulmonary tuberculosis, adult TB meningitis, then we will give similarly intensive phase 2 months of HRJD and continuation phase of 3 drugs of RHE. Okay, one point is there, ethambutol has got poorer penetration into the inflamed meninges. So we can add HRJD, that is 4-FDC, along with the streptomycin. It has got better penetration. We can extend the treatment up to 12 months and or depending upon the physician decision. For TB meningitis, we use steroids because it prevents intracranial hypertension. It also decreases the inflammation of the meninges. If the tuberculoma is there, it prevents also headache and all that. And it has, so preferably we use dexamethasone 0.4 milligram per kilogram per day intravenously in 3 to 4 divided doses during hospital stay. Then we can shift into the oral dexamethasone in divided doses, or if it is not available, then oral prednisolone 1 milligram per kilogram per day in a single morning dose. And the total duration of oral steroids should be 8 to 12 weeks in the tapering manner. we should regularly follow up those patients and regularly observe for clinical improvement. If there is abdominal tuberculosis, then similarly we should extend treatment up to 10 months or so, or depending upon the physician decision. Patient of abdominal tuberculosis can develop various complications of tuberculosis like intestinal obstructions or strictures or perforation, then or jaundice due to hepatobiliary obstruction. Then those patients will be subjected for surgical treatment with the backup of ATT. If there is intraocular TB, then we can give treatment up to 9 months and or depending upon the physician decision. Topical steroid eye drops for severe anterior chamber inflammation and systemic steroids if there is severe uveitis. For pediatric TB treatment, we have got other different weight bands. That is 4 to 7 kg, 8 to 11 kg, 12 to 15 kg, 16 to 24 kg, 25 to 29, and 30 to 39 kg. For pediatric patients, we also have FDC under the program. On advantage is it has got dispersible FDC. So patient can swallow it comfortably. So pediatric FDC is different from adult FDC because dispersible FDC has got rifampicin 75 milligram, isoniazid 50 milligram, pyrazinamide is 150 milligram. Okay. So this is available in HRZ and ethambutol is available separately of 100 milligram. So suppose a patient is of 16 kg, then we will give pediatric FDC 4 tablets along with ethambutol 100 milligram 4 tablets. But if patient is of 29 kg, then we will give pediatric FDC 3 tablets plus 1 adult FDC. 1 tablet. Okay. And pediatric patients are those patients who are under 18 years of age and weight less than 39 kg. So, pediatric, why there is higher dose in pediatric TB treatment? Because there is higher metabolism in pediatric patients of TB drugs. So, we use isoniazid around 7 to 15 milligram per kg as compared to adult, rifampicin 10 to 20 milligram per kg, pyrazinamide 30 to 40 milligram per kg, and ethambutol 15 to 25 milligram per kg. For pediatric TB meningitis, similarly, we use 2 months of HRJD followed by 10 months of HRE along with the corticosteroid to be tapered about 4 weeks. To be given for 4 weeks, then tapered over 4 weeks at the dose of 2 milligram per kilogram per day of prednisolone. Osteoarticular TB, we also need longer treatment, maybe up to 15 to 18 months. We need X-ray, MRI to diagnose spot spine or arthritis with plain X-ray. Abdominal tuberculosis, steroids are not given because it has got potential for perforation of intestine. So steroids are not given. Supportive treatments will be given to prevent malnutrition, to improve nutrition of the patient. If there is obstruction of the intestine or perforation and obstructive symptom, then we should go for surgical treatment. Now, some talk about extrapulmonary TB. So, most common anatomic site affected by extrapulmonary TB are lymph nodes, followed by pleura, bone, joints, urogenital tract, and meninges. Okay. So, once there is a lymph node, then after confirming that this is tuberculosis, we should start ATT. So, there can be, once we start ATT, then there can be symptom resolution, then we should continue ATT. But it may be there that after 3 months of therapy, there is no symptom resolution even at 3 months. And many of patients might be coming to you with increase in size of the lymph node. Okay. So if there is increase in the size of lymph node, then we should try to aspirate some pus from there and subject it for CBNAT and culture, and we should look for whether this has been turned into drug-resistant TB or not. If drug-resistant TB is diagnosed, then we should treat like this. But still, if it is drug-sensitive TB, then there is two options available. Either this can be paradoxical worsening. So in paradoxical reaction, there will be increase in size of the lymph node, or there will be new sign of inflammation up to 3 months of starting treatment. Okay. Or there can be appearance of new lymph node at some same or the other side. Okay. So this can be either drug-resistant TB or this can be paradoxical reaction. Suppose if it is drug-sensitive TB, suppose it is also not a paradoxical reaction, then there is a possibility that what the ATT drugs the patient is consuming is not reaching to the site at a therapeutic level. So we should look for the therapeutic drug monitoring by doing serum or blood examination of those patients to ensure adequate drug level. So what should be the treatment duration in extrapulmonary tuberculosis? We can see that in pulmonary tuberculosis, it is of 6 months. But in ocular TB, CNS TB extended up to 9 months and 12 months respectively. In ear, nose, and throat TB, lymph node TB, it can be extended to 9 months. Hepatobiliary 9 months. In spinal TB, it can be extended up to 18 months. And bone and joint TB up to 12 months. In all the regimen, intensive phase is only for two months, and whatever extension is needed only of continuation phase. Now, some newer recommendation has come about drug-sensitive TB in 2025, recent about 15 to 20 days. So, a treatment of drug-susceptible TB using a 6 months. WHO recommends every patient of pulmonary TB ideally should receive a regimen of 6 months of 2 HRJD plus 4 HR, but National Tuberculosis Elimination Program has included ethambutol also, so that 2 HRJD plus 4 HRE here in India. Optimal dosing frequency should be daily. Thrice weekly dosing is not recommended. FDC, that is fixed dose combination, is recommended. And if at the end of intensive phase, you still find out that sputum smear is positive, then IP extension is needed. Now they have come out with some 4 months regimen, that is HPMJ. So they have recommended that people aged 12 years or older with drug-susceptible pulmonary TB may receive 4-month regimen of isoniazid, rifapentine, moxifloxacin, and pyrazinamide. Okay, so this is under conditional recommendation. 2 months of SPMZ followed by 2 months of SPM. And in children and adolescents between 3 months and 16 years of age with a non-severe TB. Okay, if this is non-severe TB, then 4-month treatment regimen of 2 HRJD followed by 2 HR should be used. This has got strong recommendation. And for HIV and ART, all TB patients living with HIV should receive at least same duration of TB treatment as HIV negative TB patient, and ART should be started as soon as possible within 2 weeks of initiating ATT treatment in respective of CD4 cell count among people living with HIV. Steroids, as I have already told, is used in tubercular meningitis and also in tubercular pericarditis. Now some points about latent TB and TB preventive therapy. So I have already mentioned that if lifetime risk of activation of tuberculosis is 10%, but if patient is immunocompromised, then lifetime risk of development of tuberculosis or reactivation is 60%. So once we diagnose latent TB, then every patient, every person should be provided TB preventive therapy. So this is the basic idea of National Tuberculosis Elimination Program. Previously, it was known as RNTCP, Revised National Tuberculosis Control Program. So from control, it has been nomenclature has been changed into elimination. The idea behind it was that previously we were treating only disease, TB disease, but now we are not only program is not only treating disease, but it program thought the idea was that if we are not treating latent TB patients, then there is a risk that these patients are the source of further activation of TB and transmission to the other susceptible person. So we cannot eliminate TB until and unless we prevent them. So this is the basic idea behind change from RNTCP to NTEP, and it has been found that TPT, that is TB preventive therapy, decreases approximately 60% of development of tuberculosis disease and almost up to 90% among PLHIV cases. So who are the patients we should give TB preventive therapy? Patients are people living with HIV and household contact below 5 years of pulmonary TB patients. In a household, if there any source there is pulmonary TB cases, then all the household contact should be given TB preventive therapy after ruling out active TB disease. But if household contact is above 5 years of age, then we should first look for latent TB. And if latent TB is there, it is diagnosed by either tuberculin skin test, or that is called Montu test, or by IGRA test, TB gold test. If it is positive, then we should give TB preventive therapy. And other target populations are patients who are on immunosuppressive therapy, having silicosis, because silicosis patients are prone to develop silicotuberculosis, and patients who are on anti-TNF treatment, on dialysis, or who are being prepared for organ or hematological transplantation. Those patients should be given Montu test or IGRA. If it is found to be positive, then we should give TPT, that is TB preventive therapy. So these are comparison between tuberculin skin test, and you can see the quantiferon TB gold assay, TB spot test. What are the advantage and disadvantage of these three different tests? You all know about tuberculin skin test. That is, it is done by intradermal inoculation of purified protein derivative into the volar aspect of forearm, and we see the induration after 48 to 72 hours. This is in vivo assay, and there is no instrumentation is required, so it is very easy to done. And interpretation is subjective, because subjects, a person who interprets it is the induration. And only disadvantage is it cross reacts with BCG. So if a patient has received BCG, then it can give false positive result. So its specificity is somewhat low. And if a patient has a positive tuberculosis, can a patient with a tuberculin test can be repeated a tuberculin test further? Suppose a patient has been done Montu test 1 month before, then can we do Montu test 1 month after that? So it has been found that a previous tuberculin skin test can boost a subsequent such test or IGRA. So it can give false positive test also. And TB spot, that is TB gold test and IGRA test, is being done by the blood examination. So this is in vitro test. It is enzyme-linked immunosorbent, that is ELISA test. So there is laboratory instrumentation is required, where TB skin test is very easy to do even at periphery. So assay results can be affected by manufacturer pre-analytic and analytic factors. So interpretation is less subjective. So it is not subject dependent, and positivity threshold is fixed in blood test. Okay, but it is advantage is this is more specific. So this does not cross react with BCG, and a previous IGRA test does not boost a subsequent tubercular skin test or IGRA test. That is the major advantage of these tests, but this is costly. Now, few points about PSI-TB. PSI-TB is the newer skin test used to detect mycobacterium tuberculosis infection, and this can also detect latent TB. Major advantage is it is a third generation test, and it combines the accuracy of IGRA with the ease of tuberculin skin test. Okay, so this is cheaper, and this is more specific also. So it uses antigen used in IGRA test, that is ESAT6 and CFP10, and reading is read similarly as tuberculin skin test. So it is a valuable tool for the early diagnosis and treatment of latent TB, and it has been adopted in the National Tuberculosis Control Program. So this is how TB preventive therapy is done. If patient is HIV positive or household contact less than 5 years, after ruling out active TB, we should give TB preventive therapy directly. But if patient is household contact more than 5 years or other risk group, then we should do first TST or IGRA. If it is positive, then after ruling out active TB, we should give TB preventive therapy. So what are the drugs available in TB preventive treatment? People living with HIV and household contact below 5 years of age, priority is 6 months daily isoniazid therapy. Other option is 3 months of weekly isoniazid and rifampicin in person older than 2 years. Weekly means 3 months, weekly means total 12 doses of isoniazid and rifampicin. And for household contact 5 years and above and other risk group, we prefer 3 HP as compared to 6 months of daily isoniazid. So we see that 6 months of daily isoniazid monotherapy age 10 years or older, 5 milligram per kilogram per day. And if age is less than 10 years, then 10 milligram per kilogram per day. And 3 HP, 3 months of weekly rifampicin and isoniazid, total there is 12 doses. So for age 2 to 14 years and age above 14 years, there are different doses. These are available under the program. And if age is below 14 years, then we give isoniazid and rifampicin 150 milligram, 150 milligram. And as per weight band, 10 to 15 kg, 2 tablets, 16 to 23, 3 tablets, and more than 34, 5 tablets. But if age is 14 years, then fifth dose combination is 30 milligram of isoniazid rifampicin each, and we give 3 tablets in each, irrespective of the weight band. This is all from my side. If any question is there, I will be happy to answer.
For very extensive information regarding the TB and its presentation, the primary infection, the latent TB and post-primary TB, and the pathogenesis behind that, and how to get the diagnosis in a perfect manner, and how to treat. So this is very nice information. I hope the students must have learned a lot from this. So so there may be some questions, and I would like that Manish may answer some of the questions from them. Although you have explained very nicely, but there is a question regarding the indication of a steroid in tuberculosis other than meningitis?
I have already mentioned, sir.
Yeah.
It is pericarditis, tuberculous pericarditis. The risk of constrictive pericarditis in a patient of pericardial effusion. So we give steroids for up to 6 to 8 weeks. And also in intraocular tuberculosis, there is risk of blindness. There is uveitis, there is scleritis. So to prevent blindness, we give both topical as well as systemic steroids. For gastrointestinal TB, steroids are contraindicated. These, and for suppose there is renal tuberculosis and the risk of ureteric stricture is there, then also we can use steroids in those cases. These are few indications of steroids.
Very nice. Dr. Neha Kumari wished to know that whether ATT can be given without having the AFB detection, or that is basically on the clinical basis?
Yes, this is very much under the program. Suppose if AFB is negative, but the physician suspects this patient to be tuberculosis, they should go for radiology. If radiology is suggestive, we should give ATT. If radiology is also not suggestive, but there is high clinical symptoms and there is high chance of TB, and depending upon the physician decision, we can start ATT.
Yeah. So if the patient is not getting the sputum, it is really very difficult to have the AAB test done, and on the basis of the clinical examination and the presentation, as well as on the radiology, that one can give the ATT.
Sir.
Yeah. She also has a very good question. Is there novel biomarkers for early detection of pulmonary and extrapulmonary tuberculosis?
Biomarkers works are going on for different biomarkers, but they are still under no recommendation for about any specific biomarkers for diagnosing tuberculosis. So at this juncture, I cannot say that there is any specific biomarker by which can diagnose tuberculosis.
Mm-hmm. So the works are going on, and we will have to wait for the clear cut recommendations regarding the use of biomarkers for detection of pulmonary or extrapulmonary TB. So very good, very nice presentation, Manish, once again.
Thank you, sir.
So on behalf of the Dean ICP, Dr. Kamlesh Tiwari sir, and the API, I thanks you and the participants also for joining today's meeting. With this note, we would like to close the session now. So thank you again. Thank you again.